Now let's study nephritic syndrome. As we discussed earlier, nephritic syndrome is an inflammatory process and there will be increase in loss of RBC, but protein loss will be less than 3.5 grams per day. In children, infection associated glomerulonephritis is mainly caused by group A streptococcus, that is post streptococcal glomerulonephritis. This presents after 2 to 4 weeks of pharyngeal or skin infection. Pharyngeal infection like strep throat and skin infection like impetigo. And there will be positive strep serologies, and in children it can be resolved spontaneously. In adults, infection associated glomerulonephritis can present after infection by group A streptococcus or staphylococcus, and infection site is variable. As in children, infection primarily present in pharynx, that is strep throat, or skin or on skin like impetigo, but infection site is variable for adults. That is, infection will not follow after upper respiratory tract infection, and these in adults bacteria should be cultured because no serology tests are available, and in adults it is more complex. That is, this glomerulonephritis will lead to renal insufficiency. Now let's see the light microscopy, immunofluorescence and electron microscope findings. In light microscopy, glomeruli enlarges and hypercellular, that is due to complement activation, C5a activation and neutrophil activation. There will be increase in cell, glomeruli will be enlarged and there will be hypercellularity. And in immunofluorescence we can find the starry sky appearance. Due to deposition of IgG, IgM and C3, there will be on the glomerular basement membrane and mesangium, we can find the granular appearance like lumpy, bumpy. It is also called starry sky appearance. And in electron microscopy, we find the subepithelial immune complex humps. Let's see this in figures. This is the light microscopy findings. As we can see here, it is glomerular basement membrane. Glomeruli is enlarged and we can see the hypercellularity in this figure. And this is the immunofluorescence. We can see the lumpy, bumpy appearance. These lumpy, bumpy appearance this is caused due to deposition of IgG, IgM, C3 in the glomerular basement membrane and mesangium. This is also called starry sky appearance. These lumps are due to IgG, IgM and C3 deposition in the GBM, that is glomerular basement membrane or mesangium. And this is electron microscopy figure. As we can see here, these are the endothelial cells. This is the basement membrane, and this here we will have podocytes, but here we have immunocomplex deposition. This is subendothelial, subepithelial, immunocomplex deposition. In electron microscopy, we find the subepithelial immune complex deposition. These are the findings in infection associated glomerulonephritis. Next, we have rapidly progressive or crescentic glomerulonephritis. When nephritic syndrome progresses to renal failure, it is termed as rapidly progressive glomerulonephritis. And this has poor prognosis, and it is rapidly deteriorating renal function within days to weeks. In light microscopy, we find the crescent moon shaped. We will see the figure later. This crescent consists of fibrin and plasma protein. This is the main important point. Crescent is formed by the fibrin and plasma protein, especially C3b, with some glomerular parietal cells, macrophages, and monocytes. Here this is glomeruli, and this is the crescent shaped. This consists of fibrin, C3b, macrophages, monocytes, and glomerular parietal cells. And there are several diseases which progresses like this, and they can be classified into linear and negative IF or pauci-immune or granular IF. If we see linear immunofluorescence changes, this is caused by autoantibodies against the glomerular basement membrane and alveolar membrane, and this is termed as Goodpasture syndrome. These are the endothelial cells. We have basement membrane under it and podocytes. If the autoantibodies are against the glomerular basement membrane, and in lungs, these autoantibodies are against the alveolar basement membrane. If we take one alveoli, if this is the basement membrane, these autoantibodies also attack the alveolar basement membrane. Hence, patients present with nephritic symptoms and lung symptoms like hemoptysis and hematuria, especially hemoptysis, hematuria. And if there is negative immunofluorescence, it is also called pauci-immune, and there will be no IgC3 deposition. This is seen in granulomatosis with polyangiitis. Next, if in immunofluorescence we find the granularity, that is granular immunofluorescence seen in post-streptococcal glomerulopharyngitis. This is the most important point. And PSGN, as we discussed earlier, PSGN granularity is due to deposition of IgG, IgM, and C3. And diffuse proliferative glomerulonephritis is seen in SLE patients. In SLE patients, nephrotic syndrome is membranous nephropathy. Next, we have diffuse proliferative glomerulonephritis. It is a type of rapidly progressive glomerulonephritis, and it is mostly seen in SLE patients. And DPGN, that is diffuse proliferative glomerulonephritis, and membranoproliferative glomerulonephritis, often present with nephrotic and nephritic syndrome concurrently. And on light microscopy, we find the wire looping of the capillaries, and immunofluorescence is has granular pattern, and on electron microscopy we find the subendothelial deposition of IgG and immune complexes, especially C3 deposition. And we should not forget that this is subendothelial, sometimes subepithelial, and immune complex deposition is subendothelial. And to differentiate this from infection associated glomerular nephritis, here we have subepithelial deposition of immune complexes. Next, if the immunofluorescence is negative, it is also called quasi-immune. There will be no deposition of IgC3, immunoglobulin C3 deposition. It is seen in granulomatosis with polyangiitis. Here we can find the C ANCA or PR3 ANCA. And if there is eosinophilic granulomatosis with polyangiitis or microscopic polyangiitis, we find the P ANCA or MPO ANCA. That is in a slide, if we take the neutrophil and if we place the antibodies, if antibodies are against the nucleus, this is called perinuclear ANCA. And if antibodies are in the cytoplasm, we call it as cytoplasmic ANCA. And C ANCA is found in granulomatosis with Wegener's granulomatosis, and P3 ANCA is found in polyangiitis, and perinuclear, that is P ANCA, is found in eosinophilic granulomatosis. It is also called Church-Strauss. And eosinophilic granulomatosis with polyangiitis or microscopic polyangiitis, we also find the MPO ANCA. Hence, to rapidly review, a rapidly progressive or crescentic granulo. Next, see what happens in IgA nephropathy. It is also called Berger's disease. In IgA nephropathy, there will be episodic hematuria. The pathophysiology is when we get a respiratory infection or GI tract infection, IgA will be produced by the mucosal lining. When these IgA are deposited in the mesangium, this causes bleeding from the kidney. This is presented as episodic hematuria. And on light microscopy, we find the mesangial proliferation. And immunofluorescency, on immunofluorescency, we find the IgA based immune complex in the mesangium. And on electron microscopy, we find the immune complex deposition in the mesangium. All three will be seen in mesangium. Mesangium is nothing but the connective tissue between endothelial cells and the glomerular basement membrane. That is, when we get respiratory tract infection or GI tract infection, IgA will be secreted from the mucosal lining. This IgA gets deposited in the mesangial cells. When this happens, this leads to episodic hematuria. And when infection resolves, bleeding will also be stopped. And light microscopy, we find the mesangial proliferation, and immunofluorescency, we find the IgA deposition, IgA based immune complex deposition, and on electron microscopy, we find the mesangial IC, that is immunocomplex deposition. Next, we have Alport syndrome. In Alport syndrome, we only see the hematuria. This hematuria is due to Mutation in type 4 collagen. As we know, type 4 collagen is present in basement membrane and in ocular, that is on eye, and in ear. Type 4 collagen is present in these places. When there is mutation in type 4 collagen, there will be irregular thinning and thickening and splitting of glomerular basement membrane. If this is basement membrane, in basement membrane we have type 4 collagen. If there is mutation to this, there will be irregular thinning and thickening of the glomerular basement membrane. This is most commonly X-linked, and there will be eye problems like reticulopathy, anterior lenticonus, glomerulonephritis, and there will be sensory neurodeficits. And mnemonic for this is can't see, can't be, and can't hear a B. And on electron microscopy, we find the basket wave appearance due to irregular thickening of the glomerular basement membrane. Basket wave. We find like this. Next, we have membranoproliferative glomerulonephritis. It is in this condition we find both nephritic and nephrotic syndrome. This is also seen in SLE, and in MPGN, nephritic and nephrotic syndrome co-presents, and there are two types, type 1 and type 2. Type 1 is always secondary to hepatitis B and C infection, and here we find the subendothelial deposition of immune complex, and this presents as granular in immunofluorescence. Type 1 is mainly caused by hepatitis B infection, and there will be immune complex deposition in subendothelial space. And on immunofluorescence we see granular pattern. And in type 2 MPGN, here it is associated with C3 nephritic factor, that is C3 activates alternate pathway, and C3 convertase is not stable, so autoantibody stabilizes the C3 convertase, and persistent complement activation from this C3. As we know, C3 activates the complement system, hence there will be decrease in C3 level, hypocomplementemia, especially C3 level. Type 2 is caused by C3 nephritic factor, and here deposition will be on the intramembrane, that is basement membrane, and this is also called dense deposit. And in both type there will be GBM splitting, that is glomerular basement membrane splitting. This is termed as tram track appearance. As we can see here in this figure, this is endothelial cell and basement membrane and the podocytes. On subendothelium there will be immune complex deposition, and after some time this immune complexes separates the basement membrane, hence there will be two basement membranes. This is called as tram track appearance. As we can see in this figure, there are two basement membrane. This is termed as tram track appearance.